6 key areas on the agenda today: assessment and radiologic imaging, pediatric and soft tissue principles, upper extremity trauma management, the pelvis, hip, and femur, then dropping down to the knee, tibia, and foot, and wrapping up with recognizing acute compartment syndrome.
Section 1. Assessment and radiologic imaging.
Look, polytrauma patients demand strict adherence to priorities. That means airway, breathing, and circulation always take precedence over a mangled limb. You also have to identify the energy associated with the mechanism of injury, right? Because a low-energy fall dictates a totally different workup than a high-speed motor vehicle crash. And don't forget the systematic inspection. Log rolling the patient while maintaining cervical collar immobilization is absolutely essential, so you don't miss those hidden injuries.
Now, this matrix is pure gold. It efficiently maps out the absolute must-know peripheral nerve exams you need to rapidly assess sensory motor function right there in the trauma bay. Notice how specific it is. For instance, to test the deep perineal nerve, you're checking the web space between the first and second toe and looking for ankle dorsiflexion. For the radial nerve, you're checking the dorsal web space between the thumb and index finger and testing thumb extension. You've got to memorize this matrix. It's literally the foundation of your serial examinations.
Moving on to Section 2, pediatric and soft tissue principles.
Okay, the absolute crucial point here is that kids have incredible remodeling potential. This makes some malalignment acceptable, but adults, they typically require surgical fixation if an acceptable reduction can't be achieved. It's a single fundamental principle, but it completely dictates the diverging pathways of orthopedic treatment.
And here we have the Salter-Harris classification, which categorizes the 5 types of physeal plate injuries, right at the weakest part of a child's bone. Basically, the higher the Roman numeral, the greater the likelihood of a future growth disturbance. Type 1 is just a simple slip through the plate, but by the time you get to type 5, that represents a severe, often devastating crush injury to that growth plate.
All right, Section 3, upper extremity trauma management.
Let's talk proximal humerus fractures. You must always perform a careful neurovascular exam here to evaluate for brachial plexus injuries, especially in the elderly after a low-energy fall. Ultimately, stability dictates the treatment, so non-displaced fractures get a sling, but severe comminution with a high risk of humeral head avascular necrosis, that's going to push you toward primary shoulder arthropathy. With form shaft fractures, you really need to watch for acute carpal tunnel syndrome. Test 2-point discrimination, which should normally be less than 5 to 7 millimeters, and check that thumb abductor motor strength. Also, a direct offensive blow can cause an isolated mid-shaft ulnar break, which we call a nightstick fracture. And remember our rule from earlier? Kids generally get a closed reduction, while adults are going to require an ORIF, or open reduction internal fixation.
Up next, Section 4, pelvis, hip, and femur. Listen, pelvic ring disruptions are massive hemodynamic emergencies. They can easily hide 2 to 3 liters of blood loss, which means you need immediate volume control and a pelvic binder. Strict adherence to ATLS protocols is entirely non-negotiable here. And if the patient is still unstable after you place that binder, you've got to suspect an arterial bleed and consider an urgent angiogram and embolization.
For your board exams and clinical rotations, you absolutely have to memorize this classic presentation. A shortened, externally rotated lower extremity immediately signals a displaced hip fracture, especially if we're talking about an elderly patient who had a low-energy fall. These require urgent surgical reduction to mitigate the risk of avascular necrosis. It's a textbook presentation, and you just cannot afford to miss it.
Section 5, knee, tibia, and foot.
Knee dislocations are highly limb-threatening. They carry a massive 30% incidence of vascular injury. What does that mean for you? It means pedal pulses just aren't enough. You need to check ankle brachial indices. The source material explicitly points out that pedal pulse exams only have a 79% sensitivity for detecting significant vascular injury. So reduce these emergently even before radiographs are taken if you have to.
Because pillar fractures involve severe soft tissue compromise, definitive internal fixation is actually delayed. You'll use a spanning external fixator until the leg can tolerate an open procedure. These distal tibial intra-articular fractures are driven by immense axial loading forces. Just think of a floorboard crushing a foot during a high-speed car crash. Keep a close eye out for blood-filled fracture blisters, because those are severe markers of deep soft tissue injury.
And finally, Section 6, recognizing acute compartment syndrome. You have to instinctively know the 6 Ps: pain, pressure, paralysis, paresthesia, pulselessness, and pallor. These are the classic hallmark signs of acute compartment syndrome. And while it definitely happens most often in the leg and forearm, don't forget it can strike the thigh, hand, or foot as well.
But here is the most important takeaway. Never, ever wait for pulselessness or paralysis. The absolute earliest red flag is an unexpectedly poor response to pain medication, an agonizing pain with passive stretch. Those hard signs like nerve dysfunction, they show up way too late in the game. You've got to catch this early at the pain out of proportion stage.
Now, what if the patient is obtunded? In that case, a difference of less than 30 millimeters of mercury between the diastolic blood pressure and the compartment pressure definitively diagnoses the syndrome. An unresponsive patient obviously can't tell you they're in pain, so measuring these pressures is literally the only way to confirm the diagnosis and fast-track them to a limb-saving fasciotomy.
As we wrap up this explainer, I want to leave you with a quick clinical reality check. In the absolute chaos of the trauma bay, are you prioritizing the obvious, gruesome bone deformity? Or are you diligently hunting for the subtle, limb-threatening onset of the 6 Ps? Rapid revision requires looking past the distraction right to the true emergencies. Keep your assessment systematic, trust your sliding scales of priority,